It's just, oh, there we are. Now we're on.
There we go. We're live. So, hello and good evening to everyone, or good morning, or good afternoon if you're watching on Catchback. Catch up. There we go. This is coming straight after some internet issues, so there's me being a little bit flustered, but it's all good. We're here now. That's the main thing. And yeah, we're here back for another Nexus webinar, which we are really delighted to be able to bring to you this evening with the lovely Anne Howard. Anne, welcome.
Hi, lovely to be here. Thank you for having me.
Oh, it's our pleasure, honestly. Thank you so much for taking the time out of your evening to this evening. So, it's a really important topic that we want to cover, and it's all about NHS funding and NHS pathways, specifically when it comes to men. We know how tricky that can be and how uninformed patients often are, and you're just kind of jumping through these weird loopholes that you don't really know what are. So, hopefully, we're going to break down a bit of some of those those clouds of confusion and yeah, cut through that really tonight. So yeah, but before we do that, as always, we have a bit of a disclaimer, which is that Nexus events are designed to provide objective oversight, balanced information, and general guidance. Nothing shared during these sessions is intended to replace personalised medical advice. Always consult your own healthcare provider with any questions or concerns about your health, fertility treatment, or changes in your condition. So with that out of the way, I'll just make sure that the question functions is turned on. It is now. So yeah, if you have any questions throughout the webinar, please feel free to put them in the box. You can ask anonymously. I'm just double checking. Yes, that's enabled. Really important function that we are pleased to be able to provide. So yeah, let's get into it. Let's do it. So yeah, as I said, we're here this evening to really give men clear, practical guidance on navigating the NHS funding pathways and just get a clearer picture of how that works specifically when it comes to male fertility as well. And like I said, we are really pleased to be joined by Anne, who is the chair of the Royal College of Nursing Fertility Nursing Forum. Quite a mouthful.
Oh, yeah, I was going to say, try and say that fast.
Go on, do it. So you must be well rehearsed. I'll give you the.
Chair of the Royal College of Nursing Fertility Nursing Forum.
There you go.
But don't make me say it 10 times after a drink. Don't,
Was that
yeah.
part of the interview process?
Yeah.
Quite right too. And probably with a drink as well, like any good nursing function.
Of course. I'm giving us a bad name here. I'm giving us a bad name. No, it was.
You guys, there's no way you have a bad name here. It's all good. We fully recognise how the important work that nurses do. So thank you. So yeah, I guess let's get into it.
Okay.
So NHS funding and fertility funding, specifically, when it comes to male versus female pathways, where do we start? What's the kind of headline overview when it comes to that?
So when we are thinking about male versus females, and if we think about sort of where to start and when testing might be offered, so really, and I'm going to sort of speak, I suppose, specifically about couples now at this moment in time. So if you haven't conceived after a year, you're actually entitled to go to your GP and be referred to a fertility clinic for investigations. You'll be referred for investigations, not always necessarily to a fertility clinic, but you are entitled to be referred. Now, generally say a year if you are under 35. If you are over 35, that we would recommend approaching a GP after about 6 months if you are in a couple, and that's the female. Unfortunately, a lot of NHS funding criteria, as you'll hear as I get on to, refers a little bit more to the female. Now, for men, the initial testing that you'll get under the NHS will be a semen analysis, so a sperm test. And this should be offered along with, say, the female investigations. Now, my personal opinion, I think there probably should be more testing, but we can get onto that a little bit later. But that is your initial NHS testing that you will get, and the process generally will start with your GP, and they will refer you for appropriate testing, whether that is going to sort of a main hospital, whether that is going to a particular clinic, but that's usually where it starts when we're talking about NHS funding. Now, I suppose when we're thinking about funding, we sort of think it might be a bit of a blanket thing and that everybody's the same. Sadly, for fertility, it is not, which is really frustrating. And it's really frustrating for couples, for individuals when they're trying to access, funding for fertility treatment, because it is one of those things where it really does depend on your postcode, and it's pants, but it does at this moment in time, even though the NICE guidelines still say that actually couples should be entitled to 3 cycles of IVF. Many ICBs or integrated care boards, basically, they sort of make the decisions about whether you get funding or not. Actually, they don't fund 3, and it can be a little bit more difficult, and it depends very much on where you live as to what you will get funded. And I'm sure many will have come across that at certain times. I'm sure you'll have heard of that, Sean. In terms of funding. Now, as we're sort of talking about sort of access to, I suppose, male specific services, they can be funded by ICBs. They can be funded, so you can actually you do have access to specialist andrology services, and some clinics have got more specialized male fertility services, and you're entitled to ask for that. You are entitled to ask for it. Other clinics, they may not, or other spaces may not have certain expertise when it comes to male specific treatments, or they might have longer waiting lists. So actually you're entitled to actually ask for that. And one thing that I suppose I tend to, you'll get your result back from, say, your GP, and if there is an issue, then they will, hopefully refer you to the correct places, to andrology teams or specialist places. One thing I would always say is I would get your results. I would get your results, and I say this because, whether I'll get into a little bit of trouble for saying this, but GPs are absolutely wonderful, but they're not always the best people at interpreting sperm results. Okay, and again, Sean, I can see you nodding. Not always the best people at interpreting sperm results, and where an andrology team or a specialist may see an issue, someone who is not trained in that speciality may not see that issue. And what you don't want is to be told that a result is normal, and then you then think it's normal and it's fine, and actually then you find out that perhaps later on down the line, it might be a 6-month wait, a year wait, you get to a fertility clinic and they go, this result is not normal. So my bit of advice, I suppose, if you're going through, I would get your results and or at least write down a copy, get someone to read them back to you.
Yeah.
And would you agree, Sean?
Well, yeah, absolutely, because literally, I mean, I went through this now 7 years ago. It wasn't a great experience then. Unfortunately, like on our last series of the podcast, we had 10 guys sharing their stories, and some of them are going through it right now,
Yeah.
and literally recently have been misdiagnosed by their GPs. Both of them, different areas of the country, were told that they had suboptimal results, essentially. Different wording, perhaps, but that was what they're saying, like low counts, etc.
Yeah.
Then they got their results to find out they both had azoospermia, which is,
Yeah.
it blows my mind. Is even for a layperson, surely there's mostly going to be zeros across the board for the parameters. How are they getting low or suboptimal from that? So and this is why we're so grateful for you giving that advice, and for people to be able to advocate for themselves, say, and like they are entitled to get those results,
Yes. Yes.
seek a second opinion, perhaps from a more specialized person, but also to know what to ask for, like you mentioned earlier. So it's so crucial.
Oh, it's so crucial, because the treatments, a suboptimal sperm count and azoospermia, the treatments are completely different. The
Mm.
investigations may be completely different as to what you would do in that situation. So, you know, even just down to the basic of just getting hold of your result and and reading it through, and like I say, taking it for that second opinion, or if you're unsure, getting some advice on that result can really really help. And even if it's getting, even if there are sort of areas of it that perhaps could be improved, and even if those improvements are via things like diet and lifestyle and so on and so forth, speaking to someone who's specialist in that, you're going to get the advice that may help you later on down the line, instead of waiting 6 months to a year, if not longer, and then realizing there's something that you could have been doing.
Yeah, and also,
If that
like you said, the suboptimal versus azoospermia, for example, that's like a bit of a fork in the road, and the
Mm,
pathways that you then could be going on, by the time it's identified, you could be a lot further away from where you should be, and
yeah.
difficult. And this, hopefully things are. We had Anand Patel on our pod recently, who's
Oh yes.
on the GP side of things, but very passionate about men's health, has
Yes.
taken, like, by his own volition, more training in male fertility, and he's really banging the drum trying to get GPs across the country more informed, because they've run surveys about how well informed they feel, and the statistics were pretty low. Like, I'm talking like 3 out of 100 GPs raised their hand or something when they were asked who feels comfortable talking about male fertility. And yeah, so good people like him and other people in the industry and like medicine are trying to make that change. So hopefully, but in the meantime, it's about patient power, so to speak, and knowing how to advocate for yourself. Because you mentioned, it's a real shame that the NICE guidelines do stipulate the free rounds, and it can vary. Literally, you could live across the road from another postcode. And I
Yeah.
know people in London who have moved to different boroughs because of the funding differences.
Oh
And
God, yeah, yeah,
yeah,
yeah.
you think,
I
that's
mean,
so impactful on your life. You might not have ever thought or wanted to move.
oh well, exactly, exactly. I mean, and I know. Well, I think there's very few that will do 3 IVF cycles, even though that is the recommendation, even though that
Mm.
is the recommendation. And I think, advocating for yourself in this situation is it can be hard to do. I totally get that if it's, it's not an area that you're not going to be specialized in. Of course, you're not going to be specialized in it, but advocating yourself is really important. You can request, um, you can request to go to certain fertility clinics, as long as your ICB has a contract with them. Then you can go to different clinics. You can ask which
Mm.
clinics you're entitled to go, which are under this funding, and you can choose which one. You don't have to just be sent to the one that is chosen for you. You actually are entitled to ask for that information.
Yeah.
And actually, and male factor, and when you are looking, so let's say we're at that first port of call. Okay, you've gone, you and partner, you've gone to the GP, and you've sat there and you've gone, right, okay, we're struggling to get pregnant, and GP has gone, right, okay, we'll do this investigation for the female, and they leave it at that. Now, again, it is your right. You are absolutely able, according to NICE guidelines, you can ask to have your male factor tests at the same time as part of that initial assessment. And I think we see that, God, I used to see it back when I worked in clinics, and you'd get all these investigations for a female, and it would be like, well, where's the sperm test?
Yeah.
Where is the basic? Where's the sperm test? So please don't be afraid when you're sat there. And I know it can feel really daunting when you're sat in that doctor's office. Don't be afraid to go, well, what about me?
Yeah. Well, that happened to Kieran. Literally,
Yeah,
that thing, 18 months down the line,
yeah,
and they were like, "Oh, let's give you a test to find out you only had 1,500 sperm."
yeah,
Like, a year and a half down the line of focuses solely on his wife, and like
yeah,
that's where the problem lies, really. And yeah, it's a real shame, because I think even if you went there and said, well, okay, perfect example, my own experience. We went saying, I had mumps when I was 22. My balls swelled up. The issue may be on my side, but of course, they still sent my wife for testing. But that should be the way it happens. It takes two to tango, so to speak. You should both be getting referred. But if it was the other way around, perhaps, and my wife was saying, "Oh, I've got, I don't know, endometriosis or something," would I have been sent? Probably not.
Probably not. Probably not. And and again, we see it as well, and again, I used to see it back in the fertility clinics. These couples would come in, lots of history of the female partner, and lots of investigations of the female partner. Absolutely not disregarding that in any way, shape, or form. It's really important. But you'd then get to the male, and there was not even medical history, not in any questioning in any way, shape, or form. It took you to say you had mumps.
Yeah.
It took you to say that. It wasn't somebody saying to you, let's ask these questions. And that's what we should be doing as clinicians, and seeing these patients at the forefront. We should be treating males and females exactly the same and asking exactly the same kind of questions, because let's say we've got a chap who says, oh, I've got a varicocele, for example. Actually, that's going to require a specialist referral to find out, actually, can that be fixed? What can we do? Actually, that could then massively improve fertility all
Yeah.
round. So these questions should be asked. So again, please don't be afraid when you're sat there to go, what about me?
Yeah.
What about me?
Absolutely. And when it comes to when you're saying about people being treated the same, with the classic hoops that I mentioned at the beginning, like that we have to jump through for funding. Like there's all the kind of the classic like age, BMI, smoker, previous children, etc. Are there any differences between men and women, like as to what a particular sex might have to hit as a marker and the other one doesn't?
Yeah. So the criteria does fall to women. A lot of
Okay.
the time, the criteria does fall to women. So you tend to find that a woman will need to have a BMI of, say, under 30. She'll need to be perhaps, maybe under 40. It can go up to about 43, but needs to be, a lot of them perhaps under 40, under 39 in some cases. Like I say, BMI needs to be low, can't smoke, can't have had previous children. This is starting to change a little bit for men. There was less onus on men in terms of hoops to jump through, sort of, I suppose, things that you would have to do. But now we tend to find that men, the age is older. You tend to find men need to be under 30, under 35. No, that's not right. Under 55.
Right.
So under, so the age is a little bit higher. And I suppose the reason why we have those ages and why these funding groups have these ages is because with women, obviously, egg quality does reduce after the age of, I suppose, 40. It significantly reduces, so chances of success are a little bit lower. So that's why they have them there. But for men, generally under about 55, the smoking, that tends to be a big one for men as well now. We're seeing more groups that have more BMI restrictions as well for men. And to be fair, I do think these are important to think about for men as well, because without them being in there, what it's doing is it's sort of almost saying that men don't need to worry about their lifestyle. Men don't need to worry about smoking. They don't need to worry about weight. They don't need to worry about lifestyle, when actually they absolutely do. They absolutely do. And and when we go back to that question that I would hear asked quite a lot from both male and female, what can I do? This is something that men can be doing as well. So, I think it is good that those criteria are being brought in, because it does put that onus, it does emphasize that these are important for men as well. But yes, these are still criteria that do need to be met. You tend to find as well, we've got the criteria of no children from previous relationships, and that tends to cover both men and women as well when it comes to fertility treatment and funding.
Yeah, a particularly sensitive one, I think, as well, because
Yeah.
you're almost in this day and age with a lot of kind of blended families and stuff. If you come into that as the infertile partner, you're being punished.
Yeah,
For the
yeah, and
oh,
it's
you've got a child, like,
yeah,
and
you're not having any funding.
yeah,
You can't. Yeah, sorry, you've already gone and done that. You're not having
yeah,
any kind of funding. Oh yeah, no, it is. You know, I mean, and it is one to be aware of. It's not necessarily one I agree with, but it's
mm,
one to be aware of
yeah, yeah, of
when
course,
when we're thinking about those hoops.
yeah, absolutely. Um, and I know that not all NHS areas have fertility clinics as such, or fertility treatment centres. So that it might be that you have to go off elsewhere for your like further investigations or treatment with a
Yeah.
funding package. And that was certainly the case where I lived. If there was one in your area, though, so there was like an NHS hospital with a fertility function, are you able to, do you have to stick to that, or are you able to take your funding elsewhere by choice?
You can request a referral. You can request a referral. So you can so if it's found, say let's say through your semen analysis, or let's say you've got a history of things like undescended testicles or varicocele, or perhaps other urological issues that might cause potential infertility or previous cancer treatments, genetic, all of these kinds of things. If you've got any of those, you can actually request a referral to an andrologist, urologist with fertility expertise, and that potentially can be out of your area. You don't necessarily have to, because again, if you've got, I suppose, a fertility centre, that's local to you, but actually they don't necessarily have that expertise there, which is common with fertility centres. It is not everywhere is lucky enough to have that. You can request to go outside of that to then have those investigations and potential treatment. So
Mm,
yeah, again, it's all about advocating as well for yourself. You can do that now. Obviously, there is obviously you can look at private as well, but that's not what we're here to talk about. We're here to talk about NHS and remembering the things that you're right to do and what you can
yeah,
ask for.
yeah, and that's the thing. And it's not about going in all guns blazing or anything. You
No.
can still be respectful, because I think certainly I was in that place where you think, so, when someone's a doctor, like there's almost that hierarchical level of respect, and you think that because they're saying something, they're right. But if that person is a gynecologist, for example, but you are there, like you said, with one of many male factor issues, you really do want to be getting in front of a urologist or andrologist if possible. And it's
Oh, yeah.
being able to delve and ask those questions and know the difference as well, because I fully appreciate like just how confusing it is when you first start, and there's all these different titles, names, words, diagnosis, tests. It's mad, but trying to take that time to do the research and actually go, do you know what, I think we might be a better place just having even if it is a second opinion. uh,
Oh, God, yeah. And again, yeah, you can get a second opinion. There's nothing stopping you. You do not have to take the first I suppose appointment, if you like. You can get advice from another clinician if you want. You can absolutely obtain your results. You can take them elsewhere. They're your results, but you're right to actually take them and look at them elsewhere. And if you're concerned there is an issue, now, my ideal in terms of testing for men is that men went through a similar situation to what women do, and they have a semen analysis, they have a physical examination, they have their hormones tested as well. I mean, that would be you know gold standard, really, is what I'd like to see for
mm,
men on the NHS. The reality is okay, we're a little bit off that, unfortunately, but these are the things that, if there is an issue noted, these are the kinds of investigations that you're going to want to be referred for.
yeah, absolutely. And they're the first things that, if you then go off to a fertility unit, a clinic, they'll be expecting to see all that anyway, like
Yeah.
like you said, like the hormone tests, the genetic tests, etc. And yeah, a good semen analysis that has been perhaps repeated as well, because again, advocate for yourself that I think they all do know that there should be two. I was certainly asked to take a second, but
Yeah,
yeah, just knowing what you should have happened, I think, before getting in front of a fertility specialist.
exactly. Because the
Sorry.
issue is when you get in front of us as fertility clinicians and nurses, is what we're then going to ask you to have those tests. And it's then it just adds more time. It adds more time and stress onto that journey that you don't want, that you don't need.
Yeah, yeah, absolutely. I just did a bit of quick maths in my head, and you could
God,
probably see the cogs
we're
going.
whirring.
Yeah, exactly. The steam coming. I think from the confirmation of my azoospermia through to actually getting like kind of signed off for NHS fertility treatment was about 9 months, possibly moving towards a 10-month period. But I imagine that's probably quite good. I
That's
don't know. I have nothing to compare that against, but I'm guessing that we were relatively slick, and this was pre-COVID as well. Do you know roughly what the average time is, and also what people can do if certainly if like for like you mentioned female partners and that the age kind of concern about when you are hitting certain or coming towards certain points? Is there anything that may be sped up that way?
Yes, I mean, if we're taking sort of female age into account as well, you can certainly request that this is an urgent referral. You can try and expedite that process a little bit quicker, so that referral does go through. You're quite correct, actually. That was probably quite slick, Sean. That was quite slick. I mean, at the minute, again, I'm sort of, I suppose I'm out of fertility clinics a little bit, but waiting lists from NHS perspectives, can go from, just for a first appointment, can go from 6 months up to a year. It can take a long time.
Mm,
But when you are nearing those points where funding is, I suppose you're in that, say, perhaps again, it's female age, but we're looking at, say, 39 years old, and perhaps funding stops after your 40th birthday.
mm.
Then you are able to request that referral is expedited quickly, because of this funding. This is sort of the criteria that we've got. And actually, to be, that you can often, I believe it's, if you're interested in, obviously, in criteria and finding out sort of where you're based, I believe it's Fertility Network. I believe have got, Fertility Network UK have got sort of a list of funding criterias that you can look to try and find, but equally also speak to your GP and find out sort of what funding group you fall into, so you can find out the criteria that you've got to meet, and really push to have your referral sped up, I suppose. And that can happen. It can happen. Um, Obviously, you can. Again, I know we're talking, NHS treatment at the minute, but if you're wanting to sort of speed up testing, yes, obviously there is always that private option as well. There
Mm.
is that private option, and we can't hide that fact. If there are certain tests that that you need, but the waiting time is going to be a long time for those particular tests, yes, obviously you can, of course, approach the private route as well.
Yeah, and that is great that you brought it up, and it's important to address actually because it made me think of uh, like a knock-on question to that. So, say you're trying to navigate the NHS pathways, and that you're pretty sure that you are going to be eligible for it. It's just trudging through the process.
Yeah.
Are you able to get certain tests privately and then port them back across to aid your NHS funding application?
Yes, there are certain tests that you can get done privately. Usually the initial testing you can often get done privately. I would always check it. I would always check it. Funding groups are, they do change in terms of criteria. So I would certainly check what investigations you're able to get. And again, it's a way of you sort of finding out that information, thinking, okay, then what can I do with that? And what can I now get done a little bit quicker? I've known of certain funding groups that if you've actually gone and had private treatment yourself and then go back to try and get NHS funded treatment, they haven't given it to you.
Wow.
Um, yeah, because you've gone and had private treatment. I have known that before. So yes, in theory, yes, there are tests that you can get done. Often, it tends to be often your initial investigations that you can get done. And often you can, if you're getting sort of tests done, at home tests and so on and so forth, you can get those done. It's a starting point a lot of the time, and they're fine. But if you're looking to obviously go to a private clinic to have testing, what I would just do is just confirm that isn't going to damage funding, because some will be fine, but then I'd hate to obviously say absolutely yes, you can go and have all these tests done, and then there's that one group that goes absolutely not.
Yeah.
You can't do that. So yes, but I would certainly check and just make sure, because their rules do change. I've known funding groups rules to change over the years.
Yeah. Okay. And that shows kind of how tricky it can be to navigate, and especially because it can change area by area as well, which makes it a bit more confusing.
It does. But again, it's always just making sure you're asking those questions. It's frustrating that there isn't a definitive answer. It's annoying that there isn't, let's say, a national standard
Yeah.
for this is what should be done, this is what should be funded.
Yeah.
It's a shame, because it would make that process a heck of a lot easier and a lot less stressful to navigate as somebody going through an already difficult journey, and has probably already been on a difficult journey for the past year, 2 years, 3 years, however long it's
Exactly.
been.
Yeah.
You know,
Well, on that point about the kind of differences locally and by different like boards or whatever, the insert correct term here, but if funding is denied due to what is a local policy, especially in terms of men where there is national commissioning, what options do people have there?
So the first thing you can do is, if funding is denied, you can actually request a written explanation as to specifically why it was denied. And you can then, you're within your rights. You don't just have to accept a letter or somebody just saying no. You can appeal. You can request exactly why it was denied. You can make sure that aligns with actually the funding groups, published, their sort of published criteria. Make sure that aligns. You can actually bring nice guidelines into it, and when you're appealing, you can bring nice guidelines into it. But there is a complaints and appeal process that you can go through, which I like to think that your GP would be able to support you with. I know as a fertility clinic, as a fertility nurse, I've supported patients going through funding appeals because for it's being rejected, and actually, we think there's grounds for an appeal there. The only thing, there are obviously groups like you guys, like Fertility Network, like that can obviously provide advice and support when it comes to appealing. And you can look at nice guidelines for the clinical standards to make sure that it is lining up really, and use that within your appeal as well. And obviously, if you're part of a fertility clinic, your fertility clinic should be able to support you as well. The only thing I would say when it comes to appealing is you absolutely can do it, and if you believe that your funding is wrongly, has been wrongly denied, then absolutely you should do it. But it can potentially take more time.
Yeah.
That's the only real frustration, and that's something that we would always warn. Again, when back in the clinics, we would always warn couples who they felt that, and some were successful, some weren't. I saw people successful from their appeals. They can be successful, but it does take that little bit more time.
Yeah.
Because I don't think many things move overly fast when it comes to NHS funding. But yeah, that's the only thing I would say, is that if you are looking to appeal, which you are well within your right to do, it's going to add that time onto your journey.
Yeah, and that's often one of the hardest points of it all, is just seeing those days, weeks, months just go on and on, unfortunately. But yeah, it's good to know that there are options, and the first answer doesn't have to be the final answer, but
No,
it can take that valuable time, energy, emotion. So yeah, thank you.
exactly.
In terms of so I'm kind of thinking of that awesome report that you led for the Royal College of Nursing, specifically in relation to male fertility. When conducting like research and compiling that report, what were the kind of common pain points for men when it comes to the NHS fertility journey?
Oh God, I mean, one of the big is just men feeling so overlooked. You know, that was one of the really the big pain points, is even down to, you know, you're being called from a waiting room, and you know, and the clinician or nurse, whoever's calling you, calls the female patient name only. You know, that was a massive part of it, and it's like, well, actually, you know, this is about men and women. You know, and one of the big things, when you dismiss men in a fertility journey, you do two things. One, you put all the onus on women, which makes it harder, obviously, for that woman.
Yeah.
But what you then do is you then put these men into this feeling of that sort of thought process that they don't matter. They've got no sort of input into this, and that's absolutely not the case, and that's not how men should be feeling. And this can be so detrimental to, you know, mental health for men going through a fertility journey. It results in incomplete diagnosis. It results in men not being investigated. So actually, there's potential. Again, let's pull varicocele out there again and say, look, you know, if men aren't investigated properly, then, you know, and suddenly a couple is then branded as, let's say, for example, unknown infertility. And actually, there's, you know, a chap's got a varicocele, and actually, if that was investigated and he was actually acknowledged and spoken to and investigated properly, it might be, you know, find that perhaps this is the issue. This then can be fixed, and
Mm,
this can, in some cases, restore fertility.
yeah. Not to
So,
mention the potential risks of the damaged sperm from
yeah,
having a varicocele can cause on pregnancy.
exactly. You know, so, you know, there was a huge drive, and there just isn't the information, and this was what, you know, again, a massive driver really for it, is this, that when we looked at what was available for nurses, clinicians to look at and learn from when it came to male fertility, it, there was just nothing. There was just nothing out there. There was nothing, or
Mm,
very limited information out there, and that's what really spurred this project, because it gives, you know, those people who are, those nurses and doctors who are seeing patients at the very beginning at the GP surgery, so your practice nurses, your GPs, it gives them something to refer to,
yeah,
something to use, something to look at, something to help understand male fertility, so that actually when you're you know, you have this couple come and sit down in front of you who are clearly distressed, they've gone through this journey, and you've then got a bit of knowledge then to know what to do.
yeah, yeah, yeah. It's I hear all of that, and
Yeah.
what you said at the very outset about kind of being like where the female partner's just being talked to or whatever. I say always remember, it came back to me some years after, like kind of navigating it, coming out the other side. I was chatting with someone and I remembered something that at the time felt so minimizing, but then like kind of with trauma and stress, I forgot about it, but then it unearthed. But when we finally were undergoing treatment and stuff, we had this number that was like our like customer number or whatever, patient number,
Yeah.
5 digits. Both had the same number, but mine had a P after it. That P stood for partner, and I was like, "Oh, is that what I just the partner?" But also we were there for male factor as well, so I was already dealing with a tremendous amount of guilt at the time,
Well,
and then
yeah,
it's just partner. You just sit there in the corner. We'll
exactly.
speak.
And this is what we're trying to stop. And I think within clinics, you know, with education, we are trying to get out there. And our last our last conference, our RCN conference, you know, we had a talk on male fertility. You know, I think education within the fertility world is getting better. It is, in terms of fertility clinics, and much, they are getting better in terms of, supporting men and pushing male fertility. I think it goes wider though. It goes
Yeah.
much wider, and it needs to be wider than just the fertility clinics, because once you've got to the fertility clinics, you're already sort of on that journey. We need to be, one, teaching men from a younger age what they should be doing to try and protect their fertility. That's my first soapbox. We
Yeah.
then need to be teaching our clinicians who see these patients at the first port, like what Anna's doing, really, that what they should be asking and what they should be saying, even down to the part where, and this is a big one as well, is then, this was part of the project, the male factor project, was that if you are, let's say, you are a doctor or a clinician and you are starting a patient on medication that is potentially harmful to their fertility, you should be talking to them
Yeah.
about that fact.
Yeah.
That should be something that you talk to them about, and they should be given the option as to what, they should know about it and be given the option as what they want to do when it comes to things like preserving their fertility, freezing sperm before they start particular treatments, and so on and so forth.
Wow. Yeah. It sounds so commonsensical, but unfortunately,
You would have thought, wouldn't you?
yeah, isn't common practice. But yeah, like you said, with the work that's a few good people are doing, but it is increasing. Then that few will become many, and then hopefully then it will become common practice.
Yeah, I think if we keep going, consistency is key. Banging the drum, keep going, it will get better. It's frustrating that historically, even when we look, hundreds of years ago, fertility has always been so focused on female, and actually it's, that, men need to be brought into that as well, because it's important they understand and they're supported, because
Yeah.
that's a huge part of it, is that support as well, and men absolutely do need that support as well.
Well, we ain't going anywhere.
No,
It's what
good.
we're just getting started, and we every day we talk and we say, God, there's still so much more to do, but we're here. I think that's the main point. But yeah, Anne, that was great. Thank you so much. It's been really informative. Now I'll just double check any live questions have come in. No, but we have some pre-submitted ones anyway, which is all good. So like this one, I'm pretty sure it's been covered, but I will ask it because it's a question. It's almost like just a nice headline roundup on this topic anyway. So I've had a semen analysis with poor results. Can I ask to be referred to a specialist even if my GP hasn't offered it?
Yes, you can request that. Yes, absolutely. Please do. Please do. Your GP, you can refer to NICE guidelines, if you feel comfortable to. But if it's not initially offered, but yes, if you have got a poor semen analysis, then one, you can request a second semen analysis. I tend to give it perhaps about 3 months though in between semen analysis, just to give, any changes that you might be making to your lifestyle, then just give a bit of time between to let your sperm recoup. But yes, you can absolutely have request a referral to an andrologist or urologist, whoever is the best one when it comes to the particular issue with your sperm.
Okay, brilliant. Just looked at two more there, which has definitely been covered. We've been told that IVF is our only option, but I've never been offered a hormone test or ultrasound. Should I ask for that?
Yes. Please do. You can ask for that. You should. These are things. If IVF's your only option, and I'm going to assume male here as well. If that's female, then absolutely needs investigation, and actually male as well. That you can't just say that IVF's your only option with no investigation whatsoever. You can't do that.
Yeah.
So absolutely, please do push and ask for investigation for both.
It does. It happens, unfortunately. We speak to guys, and they are getting, let's say, suboptimal results, and just think, yeah, you're going to need ICSI, and like there's so that should be so far down the line as a conversation before many tests are happening in the middle.
Exactly,
Yeah,
exactly. It needs to, you need to have proper and thorough investigations before that decision on treatment is made. So
mm,
so people shouldn't be saying to you, without any investigation, oh, IVF's your only option. It's like, whoa, hang on a minute here.
yeah,
Let's do a bit of investigation and see what's going on.
exactly. Yeah, there's potentially a lot of undue stress and cost as well with that kind of
Exactly.
thought process. So, and I put that one in there myself
Oh,
because I
brilliant.
addressed the report that you headed up for the RCN last year. Have you seen any improvements to male fertility understanding and care since the publication of that report?
Yes, we have. We have. We've seen a lot more, and I see it from, I suppose, the fertility nursing perspective. We see a lot more, and a lot of the meetings that I go to now, and the fertility nurses that I speak to, they do have a lot more understanding. There
Right.
is there is more work to be done. Yes, there absolutely is more work to be done, but there is more understanding. There is more focus. We're teaching as well. We're teaching the fertility support workers as well, even so everybody through in clinics, that actually male fertility is extremely important as well, and you should be speaking about male fertility. Men should be offered counselling as well, and that is pushed. I'm seeing that pushed, so it is improving. Yes, there is still work to be done. I'm not going to deny that fact. There is still work to be done, especially on the investigation side of things. But fertility nurses are, from what I'm seeing, are a lot more aware
Mm.
of the male fertility side of things now, and being a lot more supportive.
Yeah, that's great. And I think actually there'll probably never be a phase where work isn't needed to be done, and that's not a bad thing. But
Yeah,
as long as progression is being made, and
exactly. Yeah.
and knowing that it's getting better for everyone, because something you mentioned earlier about men being kind of pushed aside and stuff. When men are included in the conversation and the investigations, just everything, it has better outcomes for everyone. Starting first and foremost with their female partner.
Yes.
It
Yes.
relieves the load on them because I know, Kieran knows, most of the blokes we speak to know, when you're in that place where you're not felt like you're included, and you then you go further in yourself, and that it's just not a good place to be. And we speak about it from having navigated that sometimes over years and come out the other side. It's hard. It's hard for everyone, and your partner, your family, your friends as well. Even if they don't know, it's hard because you're not going to be yourself. And by getting out there and getting the support that's available, like you said, it is being pushed that men are there. They're part of the equation. They need that support as well. It will help everyone. So thank you for the work that you've done with that.
Oh no, it's you're very, very welcome. It's that feeling like a team. If you're going in as a couple, you want to feel like a team, and suddenly, if the way you're treated stops that feeling of feeling like that united force in that team going into this journey, that's never going to have good outcomes.
No, no, you're right. Well, I think that is everything covered. Well, I know it is because yeah, that we've not only covered everything that I had kind of pre-prepared, but also so much more as well. So, and that
I've
was
waffled on,
awesome.
haven't I, Sean? I've waffled on.
Absolutely not. A waffle-free zone. It's all good. That's honestly, it's been so informative, and I'm really grateful. So thank you for your time this evening.
You're very welcome. You're very welcome. It's always a pleasure.
Thank you, and we'll speak again.
Speak
Bye
again
bye.
soon. Bye.
Cheers. Bye.